Welcome to Chapter 6, covering the muscular system. We'll start off with the characteristics of a muscle because these are important concepts for us to understand in therapy. Normal resting length is the length of a muscle when it's not shortened or lengthened by a contraction or an external force. So if the muscle were to just exist, the length it exists in would be its normal resting length. Muscles have four properties, and we'll talk about each of them: irritability, contractility, extensibility, and elasticity. I want you guys to be able to understand the anatomy of a muscle from figure 6.1 too. So figure 6.1 here, we have the smallest functioning unit of muscle as the sarcomere, and we can see that at the bottom of this image. And sarcomeres group together to form a myofibril. Myofibrils group together to create a muscle fiber, which group together to create a fascicle, and multiple fascicles group together to form a muscle belly. Looking at the properties of a muscle, let's talk about irritability first. So irritability is a muscle's ability to respond to a stimulus, meaning an impulse from a nerve or external stretch can result in a contraction. We can cause muscles to contract, which makes them irritable. Contractility is the ability to contract, generating force when the stimulus is applied. So without contractility, nothing happens or nothing would happen to an irritable muscle. And so we have three types of contractions that we'll talk about a little bit more in depth here later on in the lecture. But we have concentric contractions where the muscle is shortening, eccentric where the muscle is lengthening, and isometric where the muscle is staying the same length. Extensibility is the ability to lengthen when a force is applied. This is what allows us to stretch our muscles. And then elasticity is the ability to return to normal resting length when force is removed. So extensibility allows us to stretch the muscles, but elasticity allows them to return to their normal resting length. And this can also be true of a shortened muscle. Elasticity allows it to go from a shortened position back to its normal resting length. Summing up that figure 6.1 again, so a muscle is a collection of muscle fibers bound together into bundles called fascicles. Each fiber is broken down into smaller units called myofibrils. Myofibrils are then broken down further into sarcomeres, where length change of a muscle occurs. And remember that sarcomeres are the shortest functioning unit of a muscle, or of muscle tissue. And each sarcomere has actin and myosin. The actin filaments attach to the Z lines, which you can see at the end of each sarcomere, and that's what separates each of our sarcomeres. The myosin filaments are going to span between the actin filaments, and they use their myosin heads to bind to the actin and pull the filaments closer together in order to contract the sarcomere. And so when we have a concentric contraction shortening the sarcomere, we see the space in the middle where our actin filaments are not touching, that gets shortened and closer together. We have two actin filaments on each side of the myosin filament, and they don't extend to the middle of the sarcomere. So that's that section that we just talked about where they don't touch. And so the sarcomere has room to shorten because of that. The myosin heads project from the myosin filaments to bind to the actin to cause shortening or lengthening of the muscle. And so they act by like pulling the rope in or letting the rope out. And we will pull the rope in for a concentric contraction, and we will let the rope out for an eccentric contraction. Normal resting length of the muscle is shown in the top picture here, and a concentric contraction of the sarcomere is shown in the bottom picture, where the myosin heads have pulled the actin filaments closer together. So we see those myosin heads pulled the rope in, the actin filaments came closer together, and the sarcomere shortened. All of this has been used to describe the sliding filament theory. And the sliding filament theory says that the thicker myosin heads bind to the actin to form cross bridges. And when those cross bridges work to move the actin filament toward the gap in the middle of the sarcomere, we have a shortening contraction. When those cross bridges work to move those actin filaments away from the gap, we have a lengthening contraction. And when the cross bridges form but there's minimal sliding and no change in the overall muscle length, we have an isometric contraction. The number of cross bridges determines the force being produced. As the muscle gets shorter, the myosin heads run out of actin to bind to, and fewer cross bridges can be created. So we have less force in the shortened position. And as the muscle gets longer, not all of the myosin heads can reach the actin to bind, and so fewer cross bridges form, and we have less force production in the lengthened position as well. So we have maximal force production when all of the myosin heads can bind to actin, and that's usually in the mid-length position of the muscle. We have different types of muscle fibers that are designed for different tasks. Our type 1 fibers are slow twitch and are smaller in diameter, and therefore they're slower to respond to stimuli. While they're slower to respond, they're also able to hold the contraction for longer periods of time, and so they're better for endurance. They have a rich blood supply, and they're described as red fibers because of that rich blood supply. They use oxygen as their energy source. We find lots of type 1 fibers in our postural muscles because they're good for low force production and long endurance. We'll compare that with our type 2 fibers, which are our fast twitch muscle fibers. They're larger in diameter, therefore they're quicker to respond, but they relax quickly after stimulation in order to avoid fatigue because they have less blood supply. They're described as white fibers or pale muscle fibers because of that decreased blood supply. And instead of oxygen, type 2 fibers use existing stores of glycogen as their energy source. And because of that, they're very prone to fatigue, and that's part of why they have the quick release after stimulation. Type 2 muscle fibers are effective for short contractions of high force, but they can't maintain that for a prolonged period. Motor units are all of the muscle fibers innervated by the same motor neuron. So they're designed to be distributed across several fascicles in order to help preserve motor function in the event of an injury. When we've got a single neuron innervating across multiple fascicles, injury there isn't going to completely wipe out the muscle. And so it's one of those cool design features. Our greatest initial strengths come from improved motor unit recruitment, and in fact, the first 6 to 8 weeks of strength gains come from improved innervation, not muscle hypertrophy. And so motor unit activation is very important in therapeutic recovery. The number of muscle fibers per motor unit is going to vary depending on the needs of that muscle group. So our precision movements use motor units with fewer fibers per unit so that force production can be better modulated. And then our power movements don't require the same level of specificity, and they're going to use motor units with greater numbers of muscle fibers because they can produce quickly and to generate that power. The number of motor units recruited for a task determines how much force is produced. The larger the number of units recruited, the more force that is generated. And therefore, force is modulated by motor unit recruitment. The musculotendinous junction is the place where the muscle joins the tendon or starts to fuse into the tendon. And the tenoperiosteal junction is the place where the tendon joins the bone. A muscle origin is the proximal muscle attachment, and its insertion is the distal muscle attachment. Muscles have their fibers arranged in ways that align with the physiological demands of the muscle. So the amount of force that a muscle can generate is directly proportional to the cross-sectional area of that muscle. And the cross-sectional area is increased or decreased based on the muscle fiber orientation. Our parallel muscle fibers decrease cross-sectional area and extend the entire length of the muscle. This fiber orientation is good for producing larger range of motions, but not for producing large amounts of force. We'll compare that with our oblique muscle fibers, and they act to increase the cross-sectional area, making them better at producing force. They have shorter muscle fibers that attach obliquely to the tendon, so that serves to limit the amount of range of motion that these muscles can move through, but their trade-off is the increase in force production. Muscle strength and force production also depends on a few other muscle factors, including the angle of insertion, which is the angle that the muscle attaches to the bone, and that changes the amount of force that it can produce as it varies based on how the bone segment moves through the range. The angle of insertion also changes through the range of motion, meaning the force production can change through that range of motion. We also want to look at the line of pull, which is the line drawn from the origin of the muscle to the insertion to show the direction that the muscle will pull the limb segment when it contracts. And the line of pull is definitely a simplification, but it allows us to help understand muscle function in a very cut and dry way. The angle of pennation will also affect force production, and that's going to be the angle that the muscle fibers attach to the tendon that's going to be based on the arrangement of the muscle fibers, and we'll talk about that in a couple of slides here. But regardless of the angle of pennation or the angle of insertion, all of the force that's generated by the muscle is going to contribute to the osteokinematic motion, which remember is going to be our flexion, extension, ab and adduction, internal, external rotation. But it also is going to contribute to the necessary accompanying accessory movement of either traction or compression at the joint. There are multiple types of muscle shapes. We're going to talk about each of them while you can reference the image of the muscle, but know that this information is also available to you on the next slide. So our top three in this picture, our top three muscle shapes, they all have a parallel muscle fiber arrangement, which means that they're better at producing large ranges of motion. The bottom three are all oblique fiber arrangements, meaning that they're better at producing force. Looking at each one, we have strap muscles, which are long and thin with consistent width along the entire span. We can see examples of this in the body in sartorius, rectus abdominis, and our sternocleidomastoid. Fusiform muscles are wider in the middle of the muscle and tapered at each end, like what we see in the biceps, brachialis, and brachioradialis. Our triangular shaped muscles are flat and fan shaped with fibers radiating from a narrow attachment point, such as our pec major and our trapezius. And then looking at our oblique muscles, we have unipennate muscles, which have fibers extending from one side of a tendon at an oblique angle. We see this in the body with tibialis posterior, semimembranosus, and flexor pollicis longus. Our bipennate muscles look like a common feather, so we've got fibers extending from both sides of a central tendon. Common examples of bipennate muscles include rectus femoris and the dorsal interossi muscles. And then our multipennate muscles are similar to bipennate, but they have multiple tendons running through the muscle. We can see multipennate muscles in the deltoids and subscapularis. And this just summarizes what I just said on the last slide, but I would know examples of each muscle shape in the body. Muscle names are nice because oftentimes they will be named for something that helps to describe something about them that gives you a hint about that muscle. Muscle names can include their location, like anterior tibialis, which is on the anterior of the tibia. Some muscles are named for their shape, such as quadratus lumborum, which is a quadrilateral-shaped muscle in your lumbar spine. They can be named for their action, such as flexor digitorum, which acts to flex the digits. Muscles can be named for the number of heads or divisions they have, like biceps brachii with its 2 heads, biceps. Other convenient muscle names will include the attachments, such as sternocleidomastoid, which attaches to the sternum, clavicle, and mastoid process. We also have muscles named for their fiber orientation, like the external obliques, and they can be named for their size, such as extensor radialis longus, where longus is the word describing a longer or larger muscle, contrasting that with brevis, which is the term used to describe shorter muscles. Muscles can play multiple roles depending on the action you're trying to execute. So the role of the muscle can change when the activity changes, but it's important to understand the different roles that muscles can play. When a muscle is acting as the agonist, it is the muscle responsible for the desired motion. And which muscle is the agonist is determined by the size, location, line of pull, and contractile ability of the muscles. So the agonist is the muscle that needs to do the job. The opposite of the agonist is the antagonist, and the antagonist is a muscle that performs the opposite motion of the agonist. So looking at an example of these two, if we're talking about the biceps being the agonist for elbow flexion, the antagonist would be the triceps. Co-contraction is when we have simultaneous contraction of the agonist and the antagonist. Because co-contraction involves activation of opposing muscles, co-contraction is used to stabilize a joint. Synergists are 2 or more muscles contracting together to produce a motion that neither can produce on their own. A good example of this in the body would be extensor carpi radialis and flexor carpi radialis. Together, those two muscles produce radial deviation of the wrist, but neither of them can produce straight plane radial deviation on their own, with extensor carpi radialis producing extension and radial deviation, and flexor carpi radialis producing flexion and radial deviation. You can only achieve straight plane radiation or radial deviation with synergistic activation of both of those muscles. Synergists can also act to stabilize a body segment in one area in order to allow movement in another area. So, looking again at the biceps for elbow flexion, the biceps also crosses the shoulder. So, we need stabilization of the scapula by the traps and rhomboids to allow the motion to be isolated at the elbow. So, all of these muscles are acting in synergy. When this is the synergistic role the muscles are playing, they can also be referred to as stabilizer muscles, especially when the movement gets farther away from the muscle activation. Tension and tone are terms that often get mixed up, so it's important to understand the difference. Tension is developed within a muscle through a contraction. Tension produces an increased force. Tone is present in a muscle at all times. It's that little bit of tension that keeps the muscles ready to go in a normal state. We can also have abnormal tone, where the tension is higher than it should be with hypertonia, or where the tension is lower than it should be with hypotonia. But tone is present at all times. In order to produce tension, we have to have a muscle contraction, and we have different types of muscle contractions. We've talked about them a little bit throughout here, but we're going to elaborate on each one here. So it's important to be familiar with the different types of contractions and when each type occurs. Activities can have one type of contraction through part of the activity and then change to a different type of muscle contraction with even a different muscle through another part of the activity, depending on the positioning or the action that you're trying to achieve. And so understanding how the muscle is acting and how that can change through an activity or exercise is important for understanding the best exercises to select for a patient. We'll start with isometric contractions, where force is produced without change in muscle length. There's no limb segment movement involved in an isometric contraction. These are just like our setting exercises. Concentric contractions occur when the muscle attachments move towards each other, resulting in the muscle becoming shorter. So concentric contractions are typically used to overcome an external resistance. Oftentimes that external resistance is gravity, but it can be a resistance band or other exercise equipment that's providing the external resistance. In open kinetic chain movements, the insertion of the muscle is moving towards the origin. During closed kinetic chain movements, the origin is moving closer to the insertion. We also have eccentric contractions, which are muscle contractions where the attachment points are moving farther away from each other, resulting in the muscle getting longer or lengthening. We can think of these muscle contractions as being utilized to control or slow down the impact of an external force or resistance. Again, remember that external force or resistance is oftentimes gravity, but it can also be resistance applied through exercise equipment. Eccentric muscle contractions are more effective for motor unit recruitment. Not really sure what happened there, but what I was saying was that eccentric muscle contractions are better for motor unit recruitment and so are often utilized early on in recovery. And then we also have reverse muscle action, which is when we have the origin moving closer to the insertion during a muscle contraction. So taking that information, I want you to take a minute to pause the video and reflect on what you've just learned about muscle contraction types. Using your knowledge of exercise, and you can utilize resources online as needed, I want you to think about what you just learned about these different contraction types and come up with one concentric lower extremity exercise, one eccentric upper extremity exercise, one isometric exercise for anywhere in the body, and one exercise that produces a reverse muscle action. Bring your exercises to class so you can share your responses and we can discuss them as a group. Active insufficiency and passive insufficiency are concepts applied to multi-joint muscles because we have to be able to either shorten the muscle in multiple places or lengthen the muscle in multiple places to achieve active or passive insufficiency. And the only way to do that is where a muscle crosses a joint. With active insufficiency, this is a term that applies to the agonist, and it indicates that the muscle is weaker and unable to produce any additional force when it is in its most shortened position. This is because the myosin heads don't have any more actin to bind to, and the sarcomeres are all in their most shortened position. We can think about the weakness of the biceps when we try to maximally flex the elbow and maximally flex the shoulder, putting the biceps in its most shortened position. In this position, we see active insufficiency of the agonist, the biceps, but we would see passive insufficiency of the antagonist, the triceps. So passive insufficiency applies to the antagonist when it is lengthened across all possible joints. So thinking of the maximally flexed shoulder and maximally flexed elbow, we're seeing the triceps in its most lengthened position where it's unable to generate any more force to lengthen because it is passively insufficient. We will practice looking at passive and active insufficiency in class. We can use active and passive insufficiency to create compensations in the body when necessary. The best example of this is the use of a tenodesis grip in patients with spinal cord injury. We'll talk about this more at different times throughout the program because tenodesis grips are something to be familiar with. But just to give you kind of a foundation here, a tenodesis grip uses the passive insufficiency of the finger flexors to create a grasp with active wrist extension in patients who do not have active finger control. So if you're not quite understanding that, we can describe and demonstrate it in class. Just remind me or ask that question. But we need to understand the concept of active and passive insufficiency so that we know how the body helps to maintain the length-tension relationship for muscles in the body during functional task completion. So I would familiarize yourself with figure 610 in the book. And this is figure 610, and it reviews the length-tension relationship of the hamstrings in order to ascend stairs. We know that the hamstrings serve to flex the knee and to extend the hip, and if the hamstring is shortened or lengthened at both of these joints, it becomes insufficient. But the body is designed really well, and we can see that in order to ascend stairs, we position with a flexed knee and a flexed hip, shortening the hamstring at one joint, so we've shortened at the knee, and then lengthening the hamstring at the other, so we've lengthened at the hip. By shortening at one joint and lengthening at the other, the hamstring is able to maintain the optimal length-tension relationship to allow for the best force production when you then go to lift the body up onto the step. When muscles are held in a position for a prolonged period of time, they'll either adaptively lengthen or adaptively shorten, depending on if they were held in a shorter or longer position. The most common place that we'll see adaptive lengthening and adaptive shortening is going to be in our postural muscles, and adaptive lengthening and adaptive shortening typically result in decreased force production, and these muscles are weaker because of the loss of that optimal length-tension relationship. Typically, we see the point of greatest force production for a muscle in that middle of the range of motion. Remember, where the sarcomere still has room to shorten or lengthen, and all of the myosin heads can bind. But when we have adaptive shortening and adaptive lengthening, that point will change within the range of motion, and it can influence our functional strength. With adaptive shortening, we see a loss of sarcomeres, and with adaptive lengthening, we see an addition of sarcomeres. Common pathologies of the muscular system include a strain, which has a T, so remember affects the tendon or muscle fibers, and is a tear or overstretching of the tendon or muscle fibers. If a strain gets too severe, it will turn into a rupture, which is a complete tearing of a tendon. Muscles can also develop trigger points, which are hyperirritable, painful points in a muscle. And we also have tendinitis. Remember, itis means inflammation, so tendinitis is going to be inflammation of the tendon. We learn all about all this information about the muscular system in order to prepare for manual muscle testing. So once we can apply some of these concepts, we'll be able to dive into biomechanics, which will lead us into manual muscle testing, which is important for this class, but it's also an essential skill in the clinic. Manual muscle testing has specific positions that we place the muscle in for either gravity resisted, gravity eliminated, or gravity assisted position. Manual muscle testing should always begin in the gravity resisted position in order to give a true assessment of the strength. That's how we determine whether or not a patient is at least a 3 out of 5 strength, and you guys will receive that scale in class. We'll talk about the scoring a little bit more in depth, but we need that is our baseline. Can they move through the full range of motion against gravity? If they can, then we work towards the things that we need to do to score them higher. If they can't, we have to reposition them. If they cannot move through that full range of gravity in the gravity resisted position, we move them to a gravity eliminated position so that we can see if they can move through range of motion there. But we will never use gravity assisted for true manual muscle testing. Closing up for today, I want you guys to make sure you bring any questions that you have from this lecture to class so that we can address them as a group. Bring your exercises from the lecture activity to class for discussion, and be prepared for our anatomical palpation and muscular system lab activities in class.